speaking. If you have a question, please put it in the chat. We're going to have questions peppered throughout and then have dedicated question and answer time at the end. So thank you for joining us, and I will hand it over to Giselle.
Hi, good morning and happy Friday to everybody. Pleased to be moderating this session this morning. My name is Giselle Willick. I am a graduate of CHCF Cohort 17, and I'm currently serving as the Chief Quality Officer and Systems of Care for the Southern California Permanente Medical Group. I am a pharmacist by training and have enjoyed working with Kaiser Permanente for the last 25 years in various aspects of the health plan, healthcare delivery systems, and now with the medical group. I think this year of the pandemic, we've all learned a tremendous amount about ourselves as leaders, what the healthcare delivery system can do in response. And what we have today is a wonderful panel of speakers for you. And what we're going to accomplish in this morning is our goal is to understand the different layers between public health, payers, delivery systems, and really, frankly, politics. And we want to understand a little bit and hear from our leaders about the complexity involved with their decision making, how they responded to this rapidly changing and evolving care system. So what I'd like to do is introduce our healthcare leaders this morning, and we can learn about them and a little bit about their experiences. So starting with Erica Pan, tell us your name. I guess you can introduce yourself, a little bit about your role, where you work, and let's see, one notable response that your organization has led in response to the pandemic.
Sure, thank you very much. Good morning, everyone. So yes, my name is Dr. Erica Pan, and I've actually had a couple different roles over the course of this pandemic. And I'm a CHCF Cohort 12 alumni as well. So I actually, prior to now, was the Alameda County Health Officer in March when all this began. And currently I'm the acting state health officer for the state of California and the state epidemiologist, which I've been doing for about 2 months. So I'd say my most notable action was in March, on March 16th. I remember very clearly having a discussion with my colleagues in the local Bay Area health officers, and we were the first in the nation to actually order a shelter-at-home order because we saw the the increased doubling times and the increased cases in my neighboring county of Santa Clara, and we just were really concerned about what we were seeing around the globe, and it did the first shelter in place, and then have been, ever since then, really navigating the really difficult, what we've really learned is that was a really hard decision, but it was clearly the right one, but reopening is even harder. And so, now we're kind of in round 2 of that, and that's been really challenging both at the local and state level. And a lot of politics around that for sure in a public health role.
Yes, definitely, Dr. Pan. Todd May.
Hey, good morning. Good morning. I'm Todd May, Cohort 10, family physician. I am currently a senior medical director at HealthNet. And after practicing in the safety net for nearly 3 decades, most recently at San Francisco General, I joined HealthNet about 18 months ago, in no small part due to my colleague Pooja Mittal, who works there as well. And I have the pleasure of working with her very closely. I had an interesting spring. So Eric was talking about dates. I don't know if I have it quite right, but national emergency was declared on March 13th. And HealthNet started to survey the landscape and figure out what we can do to contribute to the pandemic response. The San Francisco Bay Area went shelter in place on March 17th, I think, Erica. But I knew for a fact on March 19th, I was tapped by executive leadership to lead an emergency telehealth group. And we were charged with setting up telehealth access to all of our members. Now, in the landscape at that time, we had about 600,000 commercial members who had access to a telehealth provider. And we had our nearly 2 million Medi-Cal members did not. They're primarily a Medi-Cal plan. So the leadership challenge, it was implement telehealth for these nearly 2 million people in 1 week. Now, it's a rather audacious plan and not entirely realistic, but the message was clear. This is an urgent matter, and we had to get right on it. So the interesting part's in the middle, but so I'll just jump to the punchline, which is we implemented Babylon Health. It's an innovative next generation telehealth provider, and we got the order, the mandate on March 19th. April 7th, 3 weeks later, we launched with our first 200,000 Medi-Cal members in the rural North counties. And we were live with the rest of our nearly 2 million Medi-Cal members on May 8th. So about 7 weeks in. So, not quite 1 week, but not too shabby. It was quite an undertaking. I will also I want to highlight that HealthNet granted over $13 million to 138 FQHCs across the state to support their establishment of telehealth capacity or expand their existing capacity.
Wonderful. Thank you for sharing that tremendous journey, and congratulations also on your transition over to HealthNet. Now, Felix, we'd love to hear from you. Tell us your name, a little bit about where you work, and one of the notable responses that you led in the organization.
So my name is Felix Aguilar. Good morning, everyone. I am cohort 6, so one of the early cohorts. And I am the Chief Medical Officer at CHCF Healthcare in Los Angeles. We serve mostly an immigrant community, mostly Chinese and Latino in the LA area. And we were, early in the pandemic, as Todd said, had to convert to telehealth. I remember March 19 when suddenly we were told everything was closing, and we had to close our dental clinic, our optometry clinic. And in a matter of a week, we had to do telehealth, something we had never done. Wow. And our patients were canceling their appointments. And we knew that we have patients with diabetes and hypertension. And in a matter of a week, we had to make all of these changes. So that was here in the front lines, that's what we did. Another important thing we did is we started to work with our own LA County, the HIE, the Health Information Exchange lanes. So we were to work to get those records, because many of our patients now through telehealth were being admitted to the hospital, and they had no way to get records for us. So working with the HIE and being very close about getting those records through through lanes. Also, that collaboration really made our telehealth work so much better. The other thing that we started to do our own contact tracing. When we had patients who were COVID positive with the coronavirus, they were coronavirus positive, mostly because either linguistic or cultural barriers. Patients, so we started to test our own. We started to test. Over the last 6 months, we had done probably over 1,300 tests on our own. Of course, we could send them to the county. The public health department has done some great work, but the barriers of Cantonese speakers, Mandarin speakers, of course, Spanish is well spoken, but a lot of our patients have other barriers. And so we're here, and that's what community clinics do, break barriers. And that is, I think that is the work that we continue to do with the support, of course, of many other people, as it's been said, either through community foundations, through health plans, the health departments. So that's the kind of work that we do every day.
Yeah, thank you so much. These are wonderful examples. I love we're covering tremendous ground here. We talked about shelter in place, a public health response, bringing innovation into telehealth, rapidly bringing up Medi-Cal population and FQHC, and then this interaction with HIE. Actually, Felix, I think it sounds, like that was challenging. So, what we're going to do is go into our, we're going to ask some questions here, and it sounds like we know all of these responses had to be done in a rapidly changing environment. I think the month of March is something to be remembered forever. And, that second week in March, it was bewildering, and then we've never looked back since. Even speaking for Southern California Permanente, it was previously in the primary care setting, about 20% virtual, 80% face-to-face. Literally overnight, it flipped the other way. 80% telehealth and 20% what was remaining as face-to-face, and even lower than that in the 10% numbers at some points in late March. So, it was, I think everyone has a story to tell in this area. So Erica, for you, we know these, so can you talk a little bit more about the stakeholders involved with this shelter in place? And we're going to do back and forth among the panelists here, but help us understand a little more about the complexity that you experienced. Who were the stakeholders? How did you navigate that as a leader?
Sure. There's so many different stakeholders, of course. I think everything from working with our local elected officials, so our boards of supervisors, the city mayors, and then, moving forward as time moved on, really more interaction with various other elected officials at different levels. All of you in the healthcare system trying to provide some consistent guidance. Again, at that time I was at the county level, and now trying to do that in the challenging environment of a state as large and diverse as California, to provide some consistent guidance for the healthcare system, the broader community, just the public, the business community, and then of course schools, and both K through 12 schools and higher ed. I think there are just so many different stakeholders that have a huge stake and such different perspectives. And of course, really importantly, as we all know, this pandemic has just magnified all the structural racism and institutionalized health equity issues. And that, of course, has really been front and center for all of us, and certainly I'd say one really exciting thing that we're trying to work on at the state level, but also, again, with all these different stakeholders working on, is, as you all know, we have this blueprint framework for different tiers now as far as slow and stringent reopening, and wanting to unveil a health equity metric where we're really bringing, again, equity up front and center, and trying to get the whole community around that concept to know that we all need to work together to improve that disparity, improve that gap in order to move forward. And it's really clear to those of us who are in this field and working on that, just like all of you, that that's how you have to do it. But I think making that case with all those different stakeholders is another really interesting leadership challenge.
Absolutely. How about you, Todd? You speak a little more about the stakeholders and the conflict that arose and how you navigated that as a leader.
Yeah, well, my stakeholders aren't nearly as broad as Erica's, but on the health equity topic, obviously access to care is a huge part of health equity, and in this pandemic, telehealth, really had it. This is its day, right? And getting that modality out to all of our members is a key equity issue. So I was challenged with executing basically a 6 to 12 month project in about 6 weeks. And, I was tapped to lead a major project that was outside my domain. I need to corral partners and stakeholders who I previously did not even know, deal with some internal caution and some outright resistance from some quarters, navigate complex external regulatory environments, and then we encountered myriad technical and logistic barriers. So kind of the stakeholders are the telehealth team, IT folks, the claims folks, the evidence of coverage people, marketing and communications both internally and externally to our members, legal, compliance, various business units, our corporate partners who had never dealt with before, and our telehealth provider partner. So it was really quite a task. I think the most fascinating thing is I'd been working in mostly population health domain and led our digital member engagement platform, vision and strategy and governance, that kind of thing. But I hadn't dealt with these elements of the business before, so that was pretty interesting. I mentioned some resistors, and it basically came down to folks. They didn't have the bandwidth. I kept hearing the term off cycle. We can't just do this now. We're not staffed for it. We're not budgeted for it, and this isn't how we do things, right? And it's like, well, right. This is a unique situation, and we're just gonna have to do things differently. Mm-hmm. So those are the stakeholders. Should I pause there, or
yeah, we can continue,
or go on to some, how I navigate that. So.
Sure. Yeah, let's hear it. It sounds like, you touched a little bit on, staff and resources and the concept that people believed that, well, this is, represents something new, then we need more, rather than maybe shifting or pivoting and viewing it as a way to transform. This has been a tremendous opportunity to evaluate roles of our teams, how we perform our work and provide clinical care. And the work is different for sure, and I think we're still learning a lot around this. But navigating these stakeholders, it's just essentially change management at its most intense way, to have to literally flip this switch. So yeah, I think we can can stay with this concept of, what the challenges and the stakeholders. I think it will probably resonate with many people here this morning. Felix, did you have anything to comment on, Todd's sharing? Did that sound anything like you went through?
Erica? One of the things that I have to say about stakeholders, number one, my stakeholders were my staff. And I think the CHCF and its leadership model really helped me in this, because I was asking him to do something very different. I was asking them, one, we started to do a lot of testing, and that meant bringing people who were suspect to have COVID. And that meant fear. That meant any of those folks that we were bringing to the clinic could infect them, could bring COVID into their families. So I had to be vulnerable. Vulnerability from as a leader, and tell them, yes, I'm also afraid. I'm also afraid. This could be, so doing testing in the beginning. I mean, of course, now, 6 months later, we have done 1,200 tests. We had done many other things, but in the beginning, when we started to say, okay, we're going to start doing testing in the clinic, and we're going to do this, and we're going to do that, a lot of the staff were like, uh-oh, doctor, how are we going to do this? How are we going to do that? And it required a lot of internal discussions. And I know you all went through similar discussions internally, but it required that vulnerability as a leader, to bring in your staff, to help them work together, to include them on the process, to join you on this mission-driven, the same stuff that we talked at CHCF of our mission-driven process to be successful, to move forward, and to create processes in which they felt comfortable, to feel safe. Of course, there were things that we changed along the way, but I listened, and they were like, okay, how about if we do this? How about do that? And we moved forward. And we were doing our own contact tracing. Of course, we researched it. We did things like that, to learn from the experts. You know, for public health, we work closely. We contacted the LA County Public Health, CDC, the state, and learn from the guidelines. But we were very open, you know, about the process. And I think that was really important. And following, you know, the CHCF model about vulnerability, about inclusion, about communication, all of the things that I learned in CHCF were the core of how I followed this process and the stakeholders of how I've tried to move this process along, and 6 months later, it has worked. I mean, I think they could have gone very differently. I could have a rebellion of my staff in my hands as I tried to move them to say, we're gonna do all of these things, and here's the orders, and just do them. And this is what the county, LA County says we're gonna do, and this is what we're doing. Probably not. But, so that was my experience. This is what I'd like to share with you.
That's wonderful, beautiful. I think at this time we can take a look at the chat. So is it Renee?
Yeah. So I see there's a question from Betsy. Can invite you to unmute and ask your question.
Hi, it's Betsy. My question is, for all the panel, can you speculate what the new normal might look like post-COVID, and how will this experience change our primary care delivery system?
I'll take a quick initial stab from a public health perspective. I mean, I think obviously I'll look to others about the telehealth, and you know, I think that as people are saying, the ratios of that are really going to change, and I think it's certainly just changing our whole environment. I think the flexibility, some of the silver linings, or the flexibility people are seeing now, and you know, all of us having this remotely as opposed to having at least some of us in person and some remote, really having more collaboration more broadly because of having more remote sort of technology to just collaborate. I think it'll be interesting just as far as our, you know, previous norms about personal space and how much of our physical distancing moving forward. I don't know how many of you, just even when you're watching any, you know, media or videos, and if there's crowds, it just sort of makes you cringe, I think, now sometimes, and it will be interesting to see how much of that is long lasting, and you know, some of that hopefully can help us with, you know, other respiratory viruses and other infections moving forward. I think, you know, I think what's really striking during this pandemic, and I hope this doesn't last, but just thinking again about leadership and what the divisiveness that's happened at the federal level, and sort of the rejection of science, and then trying to deal with the fears that, you know, Felix is talking about, both on the staff level and the public level, and we're really going to all face this together about vaccine. You know, we already had trust issues with vaccine, and then to have kind of the dialogue that's going on, and trying to rush things and say they're going to be delivered for other reasons. So I think there's a lot of interesting challenges on trust of public health. On one hand, from the public health side, I feel like nobody knew, except some of you as my colleagues, what a health officer was before March of 2020. And now, you know, now not only do people know who health officers are, there's a lot who are being threatened. People whose, you know, livelihoods are being threatened. We've had more than 10 health officers resign, I think, in California in the last, you know, few months. So I think really trying to bolster up, again, I think pros and cons from a public health side are that we're seeing, you know, again, people really understand what public health does and the importance of what we do and the authorities of what we do. I think, and that's all really helpful. I hope that we can also build up the infrastructure that we've sort of let decimate over decades and really build that back up over time post-COVID. But of course, that's really hard with the economic environment we're in right now too. So, and I'll let all of you speak more about the direct healthcare impacts.
Yeah, I'll say telehealth, you know, had been kind of in the background for a while, and then obviously it took a quantum leap out of necessity to really keep, to protect folks, to protect patients and protect healthcare workers. And it's here to stay. I mean, the genie's been let out of the bottle, so to speak, and patients are finding the convenience of this, and they're going to want more. They're going to want it after in a post-COVID world. Providers are getting accustomed to telehealth. There can also be efficiencies from the provider side as well. Now, obviously, telehealth is not the be-all and end-all. You can't provide all care remotely. But I thought back on my nearly 30 years of primary care physician, and just think about how many of my routine visits could actually have been done remotely. Managing chronic diseases, it's often, okay, let's see, my internet's unstable. I hope it's going through. Okay, how are you feeling? How are you feeling? What are your symptoms? Are you having any side effects? How are you doing through medications? Look at their numbers of blood pressure, glucose, and other parameters, and then make adjustments in their treatment or management. Well, they didn't have to be in the office for that, and I would say that'd be the majority of visits. And then you think about get back to equity and all that. Having the visits remotely for that type of visit that does not have to be in person can save two bus rides to the office, a half day of work for which your family is dependent upon that, and you're not going to get paid just to go sit in a waiting room and then sit in an exam room and then take a couple more buses home. Versus you get an assigned time, you log in from wherever you are, and you have your 20-minute appointments, and you're on your way. I mean, I think I think it's going to fundamentally change primary care, and I'd love to hear what Felix, who's on the front lines there, I'd love to hear what you're thinking about this.
Oh, I agree. I think that post-COVID, the healthcare system is going to be stronger. Definitely, telehealth is here to stay. There's a lot of advantages. I see patients, and we have consults when they're shopping, when they're their work. They take 50 minutes off just to talk to me, and I think that convenience is here to stay, and we're able to do them in a different settings, and so I think that we'll come out stronger. So we're going to come out stronger. This is, what they say, what doesn't kill you makes you stronger. Well, this will not kill us, but it will make us stronger. I do want to answer, I do have a question from David Campa. Hi, David. About trace contacts, and we did it in addition. We did it in support to LA County. We were not replacing the work of LA County. This was in support to LA County. We work very closely with the Department of Public Health. So this was when we did any contact tracing, we did it in support of the public health nurses who were also doing this. This was in conjunction to their work. So it was basically supporting that work and informing that work, not replacing it in any case. It was mostly helping them a lot of times with the language barriers and keeping them in contact and keeping them in the loop. So I want to make that clear that we were not creating our own little different system. We were just making sure that those patients were being contacted and not falling through the cracks. Just being good partners of our health department. That's what we were trying to do.
Yeah, thank you, Felix. In looking at the chat, seeing some themes, we'll acknowledge, this impact on staff, the providers, fear, what is community health risk versus occupational risk. I think the PPE disagreements early on and shortage did incite a lot of that fear. But for those who remained in the face-to-face, I recall encountering, a period that our specialists felt that they too, some of the conditions did not lend themselves well as much to telehealth. And there was a, frankly, I think a resentment building up over, well, I want to do that. I want to work from home, especially the hospitalists. And I think some PTSD and really just the long days and nights and just the ongoing uncertainty. So managing people and the strategies around taking care of our teams as leaders is something that's going to remain a priority throughout, in this new normal, absolutely. So what I'd like to do at this time, there are some excellent questions, and there's one here that I also see another theme. It naturally leads to this, which is, reflecting on these experiences, how would these different layers could have worked within the healthcare system, public health, payers, healthcare delivery to work together? What's working, what's an opportunity for improvement? One opportunity that I see, and I see as a question also, is about equity, and what about those who cannot access video visits? This is also widening the disparity, the existing disparities in many senses. We know that there are donation possibilities. We have lenders for video visits. There's tech checks that are done in certain populations, but all of this still requires that the patient have a champion, really. If English is not their first language, or they live alone, it's even more difficult. So this time I'd like to pose the question, how do you see how these layers within the healthcare system, how could they work more collaboratively together to address this disparity and make sure video visits and telehealth is available?
First of all, I want to acknowledge, the digital divide is a huge problem, right? Because if folks don't have, telehealth, the way I see telehealth isn't a phone visit. We've been providing that kind of service for 30 years. We didn't call it telehealth; we called it phone advice, right? It's not equivalent to a video visit. It has its place for sure, but it's not equal. And so that is a huge equity issue, and we're seeing it obviously with educating our children as well. So I don't know what the answer is there. I do want to acknowledge that divide. It's while telehealth can be a bridge to equity, it also then it falls into the trap of, well, if you can't access it truly, then there's inequity. And I don't know what the answer is, but I do like the way you're framing this is it's a public health issue. It should be a statewide issue. It should be a priority to actually focus not just on the health care delivery, how to do that safely, but how do we ensure that everybody in the state has broadband access? I mean, that is I see that as a public health issue. I see that as a education issue. It's fundamental for our state. So I don't know, Erica, if that would be I think a non-traditional look at public health. But that's one angle to take, trying to bridge that digital divide.
Yeah, absolutely. I think the other thing that's brought to mind, I think, helping sort of, and there's different angles to that as well, as far as sort of Medi-Cal and reimbursement, right, which I know are bigger issues as well. And then I think thinking about access to testing, and that's where I think there have been a lot of great partnerships, but can continue to improve a lot of these community healthcare system, and then figuring out how to reintegrate them into the healthcare system, making sure people got follow-up, both from a healthcare side and then a public health side. And then I think I did want to add on back to sort of Felix's work, and I think more and more I've seen local health departments work with different partners, especially in the peak of things in July. It clearly was just a lot for local public health departments to do. And so being able to partner with FQHCs who could not only help support and collaborate, but be able to provide those culturally competent, linguistically competent services for the communities they're already serving. I know now.
Oh, Erica.
As well, we've done some, they're going to see and need to be thinking about this typically going to be much smaller allocations that need to be controlled more. Sorry, my I wonder if that's my connection. Can you all hear me?
Yes, we can hear you. This is the reality of this digital world, and it's happening here, and we'll handle it with grace.
Right.
I'll stop.
That is Zoom meetings now. I want to go back to HIE. I think that talking about layers, and I think that health information exchange offers one way to break through the barriers among the layers. You know, because the barriers among payers, hospitals, clinics, and the way to break a lot of that information silos. Just working through our current HIE here with Lanes in LA it seems to be providing a lot of promise and a lot of good information for us. So I think it's something that you know, through the alumni network, is something we should be looking more and working more for the future, and as a very promising tool to share that information about the patients that we share, because payer information, clinical information, hospital information, they can have one repository that we can all look at, public health information, and it is the shared patient info that we can all see to avoid the HIPAA problems. So that is, I think, one of the ways to break to break through those layers. And I think that it's something that I like for us as an alumni group to work more towards, because that information that is through silos, I think that divides us. You know, we're all like, okay, well, in the clinic, we don't really know what the pay, you know, and the payer side or the health plan is doing, or what information they're keeping, or the health plan does not know much what the provider is doing from the patient side, and you know, there's all being kept in different silos. And I think that we have tools to be able to share more and to be able to do more for the populations that we serve. And I think that that's something that we, as a group like diverse like we are, it's something that we should continue to look at those tools to be able to share and push for.
Mm-hmm. Yeah, absolutely. You know, one of the big opportunities for improvement in working across these layers that I experienced, and others, and I'm not sure if I have other colleagues on the phone from the same organization, but was the balance between what the state, you know, messaging was around testing, and then local counties in different conflict with one another, and what the reality was with capacity. Not just, you know, we all recall swab shortages, PPE concerns, staffing, and time required to perform these tests, and just the messaging and the narrative. I think getting in front of that earlier would have been really beneficial. At some point, you know, certain regions within the program would work together with local hospitals and local county officials, and that began to really help us coordinate, as well as, you know, manage with clarity and expectation to the public and to the members about what testing really meant, when was it indicated, and what would you do with, you know, with those results. And I think Ellen's question is a fabulous question that actually allows us to tease out this a little further, which is, you know, what are the fiscal drivers needed for healthcare delivery systems to partner with public health to test and manage positive results for their patients. It helps that insurance covers tests in California, but what more is needed? Ellen, thank you for your question. If there were any further context you'd like to add to your question, I request that you unmute and interact with our panelists.
I'll jump in on that if Alan, do you have something to add? Okay, all right, I'll jump in. You know, the COVID testing, I mean, this is a really great topic to talk about when we're talking about the intersection between the different components of our healthcare system. You know, obviously the absence of a national strategy around testing was a major disaster. And the equipment, et cetera, the supply piece. But, you know, this also exposed the perils of our fragmented systems, right, and our very complex systems. So, you know, health plan, you know, Health Net, we sort of paid for testing under CDC guidelines, as indicated, medically indicated under CDC guidelines, paid for all COVID-related care without waive copays and all that, which was great. That's fine. And that was interesting. And then DMHC starts sending out APLs, all plan letters, and then getting into the realm of is an essential worker or non-essential worker, and symptoms, asymptomatic, and you know, it starts giving us complex directions, which we're not even equipped to actually handle that. So we'll just pay for the test because we don't have a way to actually stratify who is who. And then meanwhile, there's the public health aspect of this. It's like, okay, rather than, you know, we have a population of members who are in various communities and various pieces of the healthcare delivery system. And meanwhile, counties are trying to manage their population. I was talking about Ellen Chen, who's in the testing space for the San Francisco Department of Public Health, and trying to figure out how to do this and how to interface with insurance plans, and you know, just kind of doesn't make sense. And if we were actually, we really need a unified strategy led by public health, led by the health departments, and a different way to finance this rather than health plans paying for tests for their individual members. It's like health plans, instead direct that money into a pool of money that the health departments can use to test everybody, and kind of irrespective of whether they have insurance or not, or who their carrier is. Something like that would make a lot more sense than this fragmentation that is just creating so many challenges.
Yeah, I think those are all really excellent points, and I agree. Thanks to both you and Ellen for bringing this up. And I'd say a couple things. I think it's yet another area where even because of the magnitude and scope and of this pandemic touching all lives, that the politicization again of health and testing, I think that's where I definitely felt and still feel, you know, those that are kind of driving sometimes the messaging. I agree too that early on I felt like some of the messaging was coming from a very high level. It was just about testing more, not strategically. And I think a lot of resources got put into places where they necessarily needed. I mean, and that's actually, and then we all saw these disparities, you know, before our eyes, you know, get magnified as well. So agree. And I think we do have a lot of opportunities here in California to, again, be leaders in that. And I think, you know, some models I've seen on the local level, and I really love that thought and idea of trying to, because it has been very fragmented as far as cities, counties, healthcare systems, public health departments, all separately paying for testing and or trying to get it consolidated, where it does come together at a baseline. But even there, we've had some issues is just even the reporting of all that data. Like we've never had, you know, we had 180,000 tests per day at one of our peaks in this last week. It can be anywhere from 8,000. We had these IT systems that weren't prepared to have all these negative testing results. And now we're looking at percent positivity statewide. And I've seen one extreme where some of the local public health departments have actually issued orders to their healthcare insurers and healthcare providers you are serving.
Oh, we lost her.
Oh, I'm back. I think. Can you? Sorry. Oh, I'm so sorry. Anyway, yes, the world of Zoom and COVID technology. I was just saying, I think, that's one extreme, but if we can actually collaborate on the front end and really think about how we can provide, and, we actually have a great opportunity, and I'll bring this back with this new lab actually very soon. Perkin-Elmer is the vendor, and we're going to double our capacity in the state for PCR testing.
Yeah.
And the idea is that a combination of, having some vendors do the specimen collection, but we do want to be able to, have healthcare insurers contribute and be either build or provide to a pool. I love the idea of providing that pool. That's a model I tried to look at locally for vaccine distribution for flu vaccine. And I think we should absolutely consider that for testing. So I'll bring that back. Great ideas, and I'd love for CHCF to be able to help drive some impetus around that. So I think those are really excellent points. I think adding it to the DMHC, again, was helpful, but I think that it leaves a lot of unanswered questions about the coordination. And then the challenge as well with everything, the guidance continues to change. We're about to have another update on our guidance. And trying to navigate all the competing messaging around this, again, from the federal level and locally. But agreed, I think one really concrete thing is to really think about payment and how to better coordinate across insurers. And also, again, getting your patients the results and not only the test results and clinical management, but also common messages around isolation and quarantine and all those wraparound services that are needed.
Mm-hmm.
Hi, this is Ellen. Can you all hear me?
Yeah, we sure can.
Okay, sorry about that. I was having technical issues. Thank you both, Erica and Todd, for your responses. I think your perspectives around this, coming from different places, is super helpful to share. I think from the healthcare delivery system side of it, what I have noticed as I've talked to, and we're a relatively small shop that I'm talking about in terms of San Francisco, but the systems that have in the past set up infrastructures for population health management in terms of all the work that Prime and QIP has been trying to do, have been able to pivot with this a little bit more in terms of being able to set up testing for folks that don't necessarily require people jumping through a lot of hoops. In terms of scheduling with providers, and then having kind of a population health team that's able to manage results. So I think it has been interesting for me to see that and to think about how do we really figure out how to build that kind of infrastructure across healthcare delivery systems, particularly those that are serving the populations that are facing more disparities around any kind of public health issue. And how do we come together around payment for that?
Mm-hmm. Yeah, I'll just comment one more. I think this is such a robust conversation around testing has been, again, one of the two, PPE and testing are like I feel like the two most controversial things in this COVID response. One of the things in evaluating these different labs, so for our system, speaking for Kaiser Permanente, the use of external labs has been about 20% of the volume, and we would view ourselves as more of a population health type of organization, and still being able to get in front of the messaging, sync with the local county expectations and state, it's been a challenge and still continues to be a challenge. 560,000 tests have been done to date for Southern California, and Northern Cal is about the same. So the state of California, about 30% of tests volume has come from Kaiser Permanente. But when we look at the external claims, the costs range is tremendous, from 130, which I think is more of what's expected, all the way up to $400 for a claim from small labs, just different locations. So I think that some structure around this claims and billing process, it's out of control. And this also is a disparity issue as well, especially if people have to pay up front. I did hear, Erica, you mentioned Elk and Pelmer. Love that. I can't wait for that to come on board, and that will also help bring competition to the market and reduce some of the pricing on this as well and make it more accessible. I think there's some more questions on testing. I think at this time we're about an hour, almost an hour, 50 minutes into this. I welcome us to just take a breather for a moment. Let's do a stretch break. If you want to join me in that, and just, yeah, you can stand up if you want. I've got, take a breath, do our shoulders around. Okay, I wish we had some music, could lead us in a Macarena. Okay.
Or yoga.
That's true. I could do my sunrise salute, although it's more like midday. Okay, so I think panelists, are you ready to move on to the next question, or is there any further that you'd like to pause on here? There's Renee, is there anything else in the chat you think we should touch on? Or maybe we can try to weave it into the next question.
Sure, that sounds good.
Okay. All righty. So let's switch gears just a quick moment. So tell us a little bit, we're all people at the end of the day with personal lives too. Navigating this uncertainty, probably just long hours, and this change we spoke of for the teams we lead, our peers, and ourselves. And we all know that if you don't take care of yourself, you can't take care of others. How did you lead your teams, manage your outside pressures? Talk a little bit about how you manage yourself during all of this time as a leader. Any pearls of wisdom that you may want to share?
Oh boy, no pearls for sure, but I'd love to learn some pearls today. This is super stressful times for everybody, and both professionally and personally. And for my team, for my telehealth teams, I thought it was really important to have really constant communication about the imperative and the mission of what we're trying to do to keep folks motivated and focused. And we had long hours. I mean, there were a few weeks of 12-hour days, 7 days a week for our teams. And so, really keeping folks focused was really important. Acknowledging the challenge and the difficulty, not just like, hey, I'm just going to do this, but acknowledging how difficult it was. Expressing gratitude at every opportunity for the hard work folks were doing for a bigger mission. And, taking the time periodically to reflect, acknowledge our accomplishments, share a collective high five, if you will. I think that was really important, because because you run, go, and then stop and look back and say, wow, we've done a lot in 10 days or various points in the journey. So that's from a team perspective.
Yeah.
Felix?
Felix, go ahead, Felix.
Go ahead, Erica.
I'm similarly going to say I look forward to hearing more pearls, and I think Betsy or someone else say some mindfulness meditation sounds great. I think it's been incredibly challenging, both when I was at the local health department level and certainly at the state level. I think, like all of you, there's just so much burnout. I think many of our teams have been actually activated since January, when we first started receiving travelers and monitoring them. And so I think a lot of the same themes, I think, really trying to acknowledge. I think we're trying to do a better job at the leadership level and trying to, kind of mentor and train some people to back you up so you can actually have some time off. I think we all have to start with modeling, and I have to say I've not been doing a good job of that yet in my role, but I think, yeah, we really need to acknowledge. I think one big thing for us is really starting to look at, thinking about this new normal again of, we're in this probably for at least another year is my guess, right, of this of COVID response. And making sure you can try your best to staff that up, but also figure out what are your kind of baseline continuity of operations that you have to do that are not COVID related, and figuring out how to really clarify which staff are doing what. So many people are wearing 2 different hats, trying to do both. Some wearing 3 or more, but really trying to, and so we are at the State Health Department going to bring a consultant in to try to start thinking about all of our prioritizing our continuity of operations roles. And again, all of us, I think, had done that for shorter disasters, but really thinking about this really long term, again, what can we kind of deprioritize, and how do we have more clarity between staff to try to get people through their time back, because it is really hard. Really worried about retention. And again, as you've seen about public health leaders across the state and the country, we really have to work hard to improve our resilience and our resources for everyone in the health system. And as acknowledged, I think it's just such a stressful time for everybody.
Yeah, it's as you all said, it's been quite a stressful time. My son one day asked me that question, how are you feeling? I said, well, we do regular work, plus we do COVID work. So it's twice the work. And there were days that I thought, oh my God, how am I gonna do all of this stuff? And the early days, it was just, I felt too much. And some days I felt like, our clinic, we were a rescue ship and our patients were in the middle of a storm. And we had to convince the staff, I'm sorry, it's a little, I'm choking up a little bit, but we had to convince the staff to gather all their strength to go there, excuse me. And it was scary for a lot of people. I mean, of course, like many, so I guess some of the staff, I remember the first time one of our staff turned out to be COVID positive, and sending emails at 9:30 at night to be open and reassuring and being upfront what's happening, how we were going to handle the information, and how we were going to test anybody who came in contact, and do all the necessary information and work with public health department and all that other good information, all that stuff that we needed to do. So that's, and being over communication. You can never communicate enough. Now, this is about taking care of oneself. So, and it's been said before, it's about family, being open and being engaged. So it's been a difficult time, and I'm glad that things are we're now at a new normal, and things are getting a little more stable and more, we're getting on a new rhythm. And so things are getting, we're getting into this, and I know, and the fellowship of all of us here, it's great to know, from payers, from public health, from a fellow community clinic, folks like you. I think that it's very reassuring that we all doing some great work around the state. And so it is important, as it says, the work we do, we need to take care of ourselves, because this is a marathon, not a short rush. And so that's the important work that we do. And I think that by taking care of ourselves, we keep going, and we're open to continue to do this important work. It's been hard, but it's been good work. And I think that we should all be proud of that, of the good work that we have done.
Oh, you couldn't have said it any better, Felix. I, commend your vulnerability and speaking this reality that I think many of us actually share with you. And at this moment, we want to give you a Zoom hug. We're all going to hug you and wrap around each other as a fellowship here. This is a beautiful experience, and give ourselves some loving kindness, okay? We've all done, this has been a beautiful moment, and thank you for sharing with all of us.
Thank you.
It is like an ultra marathon is what we're calling it too, an Ironman. This is not your run of the mill.
Our woman.
Yes. Okay. Let's see. Renee, is there any other comments here in the chat that we did not address yet?
There were a couple of questions, one about living in a rural county and most of the testing being done at FQHCs coordinated by the county, and that it's actually working better for them because they're getting results back in 2 to 3 days instead of 7 to 10 days. Mm-hmm. And then another comment and question around, is there a way to get more testing capacity by doing sewer testing or some sort of pooled testing instead of trying to get individuals to go and get tested? Are there other innovative ways?
Yeah, I can definitely talk about some of the things that are happening and or we're looking into at the state level. So pool testing, there are some centers in the state already that are, I think actually now validated as well. I think Stanford and UCLA have been starting to do some pooled testing, and like you, I think we hope that will become more widely available. I think again, it has to be, and it does look like we're heading in the right direction for that. That is most useful, at least with certain technologies now, when you have a low enough prevalence that it actually still saves you time and saves resources, because some of the early technology around pooled testing, you still have to, if you have a positive, you still have to then redo sample. I have seen another new which one is positive amongst those, but so that's definitely, I think, much closer to being more widely available. And then wastewater surveillance is absolutely, I think, in fact, there's a call this morning with the CDC. There's again some great work happening across the state with different water districts and some academic partners that are working on that. Again, that's really more useful when we're at lower levels, which again, we're hoping we're getting to that. Although I will just say, while I'm thinking and talking about this to all of you, I think we're a little worried and we're having some messaging coming out today about, we look like we're plateauing a bit. We had done a great job, as this makes sense, about 3 weeks after starting to reopen more, and about 2.5 weeks after Labor Day, we're starting to see some plateaus, maybe some upticks and ED visits. So we really all need to not let our guard down and continue to reiterate to the public. But when we do have levels that are lower, and there's some granularity that can happen with the wastewater surveillance, so you can do broad testing at a large, water district, and then if you have blips, for example, or once you're down to negative and then you test it, you could start to get more, look at the different sort of literally pipelines and start to narrow in where that's coming from, or it might be helpful at certain, I think one really fascinating area that we'll be looking into is, certain SNFs or prisons that are high risk settings that it is hard to keep testing everyone all the time, and trying to be at that very more focal level for that. So I think the bottom line is they're still validating sort of the methodology around that, sort of statewide and nationally, but I do think that is something that we just got some funding for at the state level to work with the CDC and others, and that will be on the horizon, but I think will be most useful in those two settings, either really high risk settings, locations where you can actually do testing right there, as opposed to doing clinical testing of all the staff and residents. And then once we get down to a level that's much lower, it can be like an early detection, early warning system. But I think the quantitative is still, of course, even further out from being able to qualify or be useful. So it can somewhat be useful for trends, but I think it'll be much more helpful when, as a state level or even in regional levels, we get to lower community transmission levels.
Mm-hmm. Yeah, thank you, Erica, for that. And what's fascinating in the state of California is this broad difference, actually, that we see in positivity rate, right? And in the Northern California, some certain Northern California regions versus Southern California regions, and where the hotspots are, they're not exactly the same. It's like these micro pockets, and then it can change where it's a hotspot in one area, in one county, and then 2 weeks later it's something else. And that's been, I think, a challenge, kind of chasing that bus a little bit. And if we could do more surveillance, we would be able to predict more of this. And I think that's where we really need to be focusing on as well, and really helpful to hear your perspective from public health, Erica. I am excited about the state contact tracing public health initiative. And the partnering around that, the amount of the California population that can potentially be touched by that initiative, I think is a great grant. I think this, I think there's much to learn internationally too about what other countries have done around this pool testing, wastewater. I think it's just an exciting growing area. I can't imagine how many young college kids at this point now. Epidemiology is probably one of the popular fields of studies. Let's see. Anything else on that, Erica or Felix or Todd, to add? Okay.
Giselle, you want to take a couple more of the questions from the chat?
Sure. I saw one on education. Let's see.
Yeah, Judith, would you like to unmute and ask your question?
Yeah, I mean, I'm not sure if it's really appropriate. I mean, I guess when I saw David Lowndes' question in there about how we could possibly use some of these bigger entities to get a better sense of providing testing for schools, which are really, at least where I live in San Francisco, are really underfunded, ironically, and unable to provide the kind of testing that we would need to have students go back to school. And I'm not sure if it's really appropriate for this panel, but I find the lack of conversation about the impact on our children and education kind of shocking. And I do think it's a public health issue. It impacts many of us. It impacts many of our staff, because they actually are hindered and unable to work. Anyway, I guess it's just something I've been thinking about, and some of the chat and the conversations have just got me thinking. And it's like, if any group can address it, it would be this one.
Hi, Judith. I'm sorry I went in and out. I'm having technical difficulties and Wi-Fi problems here, but I did hear the end of your question, which was about, I think, about schools. And I'd say at the public health level, it's like one of the most active conversations. And I absolutely agree. This is, such a broad societal impact. And it's another incredibly divisive topic, actually. I mean, there are so many, I get, tons of emails about, why aren't they reopening sooner, to why are you letting them reopen? And I think the dialogue that's going on with our teachers, I think, is really, yet again, I think, to me, a demonstration of how we've undervalued a certain really important group in our society who are there to take care of our kids, but they don't feel safe. And then back to your, really concretely, your testing question. Definitely one of the big priority populations for the Perk and Elmer Lab is to help with school testing, and we're trying to update our guidance on that actually as we speak as well, but it's going to be a huge priority. And then there's this request for innovative specimen collection sort of proposal that's out there right now for people to come and help us with. I think high priority populations are going to be schools, and then other hard to reach populations, and again focusing on speaking of hotspots, we're still seeing it's improving, but still seeing a lot in the Central Valley and again, some of the rural areas that are just having a harder time getting enough testing access. And then pediatric testing is certainly an issue as well. And I hope as more technology, you know, the PerkinElmer's one at least is mid-nasal and not nasopharyngeal, so that's certainly easier for kids and everybody. And as we can get more sort of saliva testing and other things. But I totally agree. I think it's, you know, the impact and yeah, the impact of kids just not being in structure and not being there, but also, you know, as we've seen across the country, you know, some places opening early and having large outbreaks right away and trying to balance that. And again, it's incredibly divisive. It's really been fascinating. I think there's a lot of great work, to your point, in San Francisco. Dr. Bardock at UCSF is doing great work with SFUSD, and LA Unified also is doing some great work. But bottom line is we are trying to prioritize, especially sort of public school districts and places like that when we get this PerkinElmer up and running, having a lot of dialogue with CTA and CDE on how to kind of operationalize that. So agreed, we need to get our kids back in school and we need to figure out how to do it safely, and so much controversy around that issue. But absolutely agree. It's like, and to your point too, if healthcare workers can't work, if their kids are, you know, especially young children, I think, you know, I feel like my kids are old enough that they've just been like on their own for 6 months, I feel like, but it just, yeah.
Yeah. Thanks for addressing it. I also think it's a huge equity issue as well. I mean, I'm very aware of my children, you know, they'll be fine.
Judith, how old are your children?
16 and 18.
Okay. Yeah, this is a very common question. I'm wondering, hey, how many people have children in distance learning? You know, you can see you raise your hand. Yeah, there's lots of us, right? And since when did you think you'd have to be a tutor, a proctor, the principal, the lunch lady, you know, all the different roles at the same time having to be a professional? It is is hugely challenging. And I don't know that we can fully see the impact on our kids and education for some time, but I think this is a top priority area, and I see a lot of comments agreeing. So really thank you, Judith, for opening the door for that.
You know, this is such a huge topic, and obviously this distance learning it's an inferior quality education for sure. And you know, I have teenage kids, and yeah, they're pretty much on their own, and they're doing their thing, and they'll manage to get through this. So it is an inferior educational process, but there's also the developmental piece of it, the socialization, the interaction with peers. You know, I can't even, we talk about this a lot as a family, but it's hard to fully comprehend the impact of the situation on our children who are at important stages of development and living, you know, not leaving the house except to take a walk in the neighborhood. It's hard to fathom exactly how deep that impact is. So this is a critically important issue.
Yeah, thank you. And I did want to highlight, we did have a question from Alan and Anne about, you know, it's one thing to be a highly paid health professional who took an oath to care for people, even if you're exposed to risk. It's another to be paid $15 an hour to play essential roles in healthcare and education where you never took an oath to put yourself at risk. Can we expect a leveling of payment, or are teachers and medical assistants expendable? And maybe, you know, Felix, if you want to, you know, give your thoughts on that.
You're correct. I mean, of course, our medical assistants, you know, who are also paid minimum wage, are, you know, folks like that who are on the front lines. A lot of that, I think that it's a tremendous risk that they take. And I'm one that I think that we need to start rethinking a lot of those wages, a lot of that, and also genderize, because let's recognize that this is in many ways is women's work. That's a lot of the frontline is gender and also people of color. So it's also POC work. So it's a lot of that. Let's remember that COVID has shown that people of color, women have taken the brunt. So those the infection rates have not impacted equally, and it is something that weighs heavily me and in a lot of people's mind. And I know that the State Health Department epidemiology reports point that out, and I know that Erica can also point that out, that is something that in issues of equity, we need to keep working for that, for a more equitable and just society. And I think that CHCF has never been shy to talk about these issues, and for us to keep working for that. So I think it is important. It's an important discussion, and for us to talk about it and be in the forefront of change.
Yeah, thank you for that, and love the additional comments and feedback, sharing similar thoughts on this. So we've been on this journey this morning together. We are approaching the final 10-15 minutes of our time together. And this is an opportunity for us to share with the panel, what is one of your biggest takeaways over the last 6 months? And in hindsight, you knew what you knew now 6 months ago, which probably in some ways feels like 6 years, 6 decades, put any number on that. It's just so much has happened during this time. What's one thing you would do differently? Todd, should we start with you?
Yeah, I heard 2 questions. The last was, what do you do differently? I think the first is, what's your takeaway from this? And first, I want to really acknowledge Felix, and your earlier comments were just so powerful and important. And for me, I spent all this time, all these years in the safety net, and we've been through SARS and MERS and H1N1 and Ebola, and I knew what that response was like, and here I was no longer in that space, and I frankly had no idea what a health plan's role could be in a pandemic. I was very naive about that. I really, when questions started coming, what are you doing about COVID and the health plan, the actions on the front lines? But it turns out there's a lot that we could do. So that was a huge learning for me. And in terms of covering costs.
It's a little hard to hear you. Could you speak up a little bit or increase your volume?
Yeah, I'm sorry. It's probably my internet. I'm not sure. Is this any better?
Yes.
Yeah.
Okay. Everything from waiving copays, paying for testing, to telehealth. That was a tangible thing where we could contribute to provision of care, because we're not a healthcare provider. So that was really, frankly, eye-opening for me, because I just had no idea of what a health plan could do.
Okay. Erica?
So I think what are my big takeaways, and what would I do differently? I think, I guess a couple things I would do differently would be, I think one of the big themes that we have talked about is equity, and I will just acknowledge, I think for all of us, this all just happened at a scale and rate so much faster than anyone could have anticipated, and so I think most of us, including myself, are very much in reaction mode rather than proactive mode. But I think some of the disparities we have seen magnified were very predictable, and maybe trying to nip that in the bud even earlier. And I think related to that, I think a lesson learned, and just continuing to try to advocate and continue again on health and science, and really I think collectively doing our best to to advocate for what we think is the right thing and based on the science and the evidence. And I think, you know, again, the politics of this pandemic and this disease have been really fascinating and really challenging. I mean, again, I think the faster reopening in the summer, I think there are a lot of lessons learned around that, right? And it's already happening again now. We're just starting to decline, and there's so much pressure again to do things faster. And there's certain counties that want to go faster and are just gonna, you know, go do their own thing potentially. So I think just continuing to work with, you know, and I guess one of the first questions about stakeholders was working with stakeholders and trying to have broad community unification around, you know, these really important things we have to do together are really important lessons learned. And the one I did take away from today even is just we all really need to work to take care of ourselves more and to figure out how to take care of our staff, because I think it's just, we are in it for an Ironman, and I think people are really, you know, we're really losing, I think, resilience. So we need to work collectively on how to do that.
Mm-hmm.
I will say that lessons learned, number one is science is not enough. And I say that because I work, you know, in healthcare, and, you know, I'm thinking, oh, I'm surrounded by doctors and nurses, and I can just show them this science. That would be enough. That's not enough, of course, right? So what I mean by that is, early on I thought, oh, okay, if we just explain them the science and the facts, that will be enough. And I think that maybe the Trump administration knows that very well, and they can use rumors and innuendo and falsehoods, and that's enough to undermine a lot of what. And you really need to engage people and communicate and talk about their fears and talk about what's underlying that to really get true action and motivate them, not just hear the facts and we're scientists, we know better. And that worked better. And also, here's our mission, and that was more engaging and better results. So I think that's a lesson learned, you know, and I think the last 4 years of what's been going on has shown me that that's one lesson learned. I also, of course, another lesson learned is to be nimble and to be quick. I mean, wow, telehealth implementation, that was fast, and we had to be fast. We had to be nimble, and we had to change our methods and really fast. So I think that this is that's the other things that I think that I have learned and will carry on for the future. So I think that those are the lessons learned that I carry.
It's wonderful. Thank you so much for sharing. Todd, potential is limitless in our careers ourselves as professionals. We're constantly growing. Again, congratulations on your change in your career and the great work you're doing. And Erica, you know, public health officer, helping really define what this really is, bringing awareness and sharing with the whole state of California and nationally your expertise and taking care of ourselves. You know, we've been in reactive mode. It's time to, you know, stay in a proactive position as best as we can, and remember that caring for ourselves is important so we can be there for our teams and others. And Felix, you know, closing us up with, this is more than science. It takes more than just sharing just the facts. You know, you have to appeal to, there's a lot of messages to cut through, and people don't know between what the government is saying and what our medical literature says, where's the best way to communicate this So I just want to thank all of you for your time today. This was a very rich conversation. I've thoroughly enjoyed it. I hope all of you have as attendees. And, you know, this takeaway question, I hope we're also asking this of ourselves as participating in this panel this morning. I think this continuous growth and leadership is something we're all committed to, and the reason why we still stay connected with this fellowship, and you know, we'll work together to continue to do great things in the state of California. And thank you to Renee and to Gina for arranging this session and inviting all of us, including me, as your moderator. So at this point, I'd like to hand it back over to Renee and close us out.
Thanks so much. And yeah, I want to just echo all the things in the chat for all the panelists. Thank you for stepping up, stepping in, and being vulnerable here in this space. Really appreciate all the work that you're doing in your respective roles to help all of us stay and continue to be healthy. So thank you. We have a handful of minutes left here. So if people have questions where they want to, I think, just openly ask them of any of the panelists, we can spend the next few minutes doing that. And we will leave this line open. The next session will begin at 11. So we look forward to seeing you all continuing here and again then. So thank you so much.
Thank you, Todd. Thank you, Erica, for great panel.
Thank all of you.
Thank you.
And Felix, thanks for your vulnerability. It's really touching. We're all in it together. So yeah,
Thanks.
you all.
Thank you very much. You're so inspiring. Thank you.
Yes.
And thanks, Giselle, for leading the conversation.
Oh, it was great. I learned so much this morning.
Does anybody have a question that they want to ask any of the panelists? Or a comment or a hello? We don't have to be so formal.
Yeah. I like everyone's backgrounds.
David Compa, I had a question.
Yeah.
I work down in LA County Department of Health Services, and we're really focusing on vaccinating against influenza so that at least we have that taken care of as we enter the flu season. But we've heard a lot of talk in the community and among our patients that we're maybe mixing COVID-19 vaccine with the flu vaccine, another kind of mistrust of the healthcare system around influenza vaccination. I was wondering if there's any plan to do any marketing, maybe at the statewide level or through health plans or whatever, to let the public know that the influenza vaccine is safe and it's something that we strongly encourage.
Yeah, thanks for bringing that up. I just learned about that circulating sort of myth, and actually in certain communities, unfortunately, our hardest hit. I've heard that widely circulating in our Latinx community is also a concern that even with COVID testing, that actually people are trying to introduce COVID when you're testing for COVID. So, but I think back to Felix's point, you know, this is where we're really learning. We need to find our trusted community leaders to disseminate these messages, because you know, there's been a loss of trust of government for sure, and for some public health. I mean, there were protests yesterday across the state at public health departments and to public health officials. They actually had everyone in Sacramento not show up because there were going to be protests. I think it turned out not to be a huge one, but yes, we are you know, actively working, standing up a vaccine task force, and a huge chunk of it is around communications. But I think what we need to do is partner with all of you on the front lines, and with your kind of community-based leaders that are really the trusted ones. Because I think, you know, I can't agree with Felix more about, I learned this a little bit with vaccines in general and some of my work on immunization advocacy, and that science is not what compels a large number of people. So I think, yeah, I think it's another great thing that we should partner together, and really for you all to be, again, if you have that are front lines and or working with community-based organizations that are really the trusted, working with our faith-based leaders. We're trying to do that somewhat statewide, but I think that really needs to happen again at the local level. We're certainly going to try to provide more and more tools. We have some great campaigns, El COVID and the Rona, and actually I'll try to make sure I send that through CHCF so you can all see some of those PSAs. But I think those are sort of trying to be, speaking to our audience a little bit better. But we will continue to try that. But I think it's going to be also a heavy lift that we all need to do together. Thanks. Thank you, Erica.
Yeah, this is Jay. That's a great point about flu. I think there's a lot of concerns about, the quote unquote twindemic, right? And certainly we've been doing our part to try to move the needle on that. And in a weird way, I think with COVID, it's created some fear in some of the communities that we serve and motivating for people to actually come in. I think my success rate has been a little bit better in selling the flu vaccine. It's sad that we have to sell it to our patients. But I wanted to ask, and I missed part of the conversation due to kind of having some electrical issues here at our mobile unit, and wasn't able to beam in a little bit earlier. But specifically regarding, I guess, like services for people experiencing homelessness, and I know that there were efforts to really get folks housed through Project Room Key, et cetera. And in some areas, I think it's worked really well, and in others, it hasn't. And I think part of what I'm concerned about is when sort of immediate funding runs out, for folks who are at risk, how do we get them bridged to more permanent, situation where we're not ending the project because, the funding's run out, and then we're, back in the situation where people are back out on the street.
Clearly, there's an easy solution out there. Everyone's jumping up to.
No, I know it's not an easy solution. Maybe it's a rhetorical question, but obviously we're all going to do what we need to do. But I'm wondering, as sort of the immediate flood of cash that came in to deal with the first part of the pandemic, now that we know that we're in this for the long haul, how do we create, I guess, sustainable funding, to maybe use this as an opportunity to really get, more people housed permanently?
I will say I have seen, and I'm hearing about local governments starting to your point, kind of leverage that there was CARES funding that came in and Project Room Key and actually investing in longer term housing. So I do see and hear about that happening at the local level. And again, I think some collective advocacy around that is really important. But certainly homelessness has gotten even worse, and then trying to address that and increasing housing. But others may have other solutions. I'm gonna have to jump off, but again, it's really great to see all of you, my CHCF family. So really nice to see you all. Take care.
Bye, same here.
Okay. Yeah.
Bye, everybody.
Thanks, everybody. Have a great day. Bye-bye.
Thank you, Todd.
Take care. Thank you. Bye-bye.
Hey, Jay, if you're still on there. Or did you leave me? No, there you are.
I'm still here.
Okay, good.
I'm still standing.
Okay. First of all, great to see you. I do have a contact that is on the state appointed board, and I don't know what it's called, but it's a state appointed board who is working on homelessness. So governor appointed. So I could connect you with him and maybe open a dialogue to see what they're doing at that level. And I know that homelessness is a passion of his. He did a lot of work out here in Riverside. And now he's working out in, I think it's Oxnard. So he took a position out there to work particularly and specifically on homelessness. If you think it would be worthwhile, I'd love to connect the two of you. And maybe you guys can have a dialogue and see if anything comes out of it.
Yeah, that sounds great. I do know that the opportunities for us, we were recently able to snazz up an old school RV and build a mobile unit. But I think that's part of the process to getting us to, reaching people outside of the four walls of our clinic. But it's interesting because I think as people have continued to, provide services for people that are experiencing homelessness, what we're finding is that it really does accelerate because there's a lot of need out there. And even for counties that feel like they have, that they're, swimming in cash, like Orange County on the outside, the truth is we have, some real pockets of need and vulnerable populations. So yeah, I'd love that contact. Thank you.
Great. And then also for Orange County, I know America does a lot of work around LHA, right? Does a lot of work around a bunch of other stuff. So I'm hoping that you're connected there. I don't know that she focuses on homelessness, but I know that she at least has resources in the community and has quite a, connections in other areas that might be a worthwhile connection.
Yeah, she and we have connected, and we're able to do some work together on getting COVID testing out to communities. So you're right, she's a force. And I also didn't realize that her son is actually a family physician here in Orange County. Who knew?
Well, see, I didn't know that either. I just know that she is and everything that she's done in the community. So, okay, so good. I'm glad that you're connected. I'll connect you to Emilio Ramirez is his name. And I'll just send an email or a text or something. I'll figure out how to connect you. And then, we'll see if anything comes from it. And I'm hoping that it does.
Right on. Thank you.